In this video, let us look at intussusception. Look at the spelling here. Intussusception. Okay, difficult spelling there. Basically, what is it? It is invagination of one segment of intestine into another. One segment of intestine is going into another. So let us say the food is going like this. Okay, so and let us say this is the ileum and this is the cecum. Okay, so it is going from small intestine to large intestine. Let us say. Okay, this is what the food is going, right? So what happens here, this is the proximal part and this is the distal part, right? So this proximal part enters the distal part because this large intestine is kind of big and small intestine is small, right? You can understand. So this proximal part can get into the distal part. So this is the intussusception. When you look at the cross section, you will see this is how it looks. See? And it is kind of narrow here, right? So this is the intussusception. Intussusception, let us say, because of the spelling, intussusception. Definition: invagination of one segment of intestine into another, usually proximal into distal, is called intussusception. It will cause intestinal obstruction, especially in a 1-year-old child. Okay. So this topic you might have seen in pediatrics also. So what are the parts of intussusception? Look at the parts here. You have whoever is receiving the intussusception, that person is called a recipient or Intussusception. Intussusception is the recipient of this intussusception, or it is also the distal part. Okay, usually the distal part or the outer tube. The outer tube is the recipient. It is called as intussusception. Whoever is entering, that person is called as intussusceptum. Intussusceptum. Intussusceptum is entering. Okay, and what is apex and what is neck? Look at this. Okay, apex and neck. So apex is this part which is advancing inside. Okay, and neck is this narrow part. Okay, so basically we are showing, always remember, food we are showing towards this direction because we are trying to show you small intestine and large intestine, small intestine entering large intestine, or the ileocolic variety, which is the most common. Okay, so that is why we are showing you that from that time. Okay, that food is going in this direction. That's why they are trying to show. What are the types? The simple ileocolic is the most common type, followed by ileal and colocolic. So this is the one which is most common. What are you seeing here? Here you see small intestine has entered the large intestine. This is the simple ileocolic. Okay, ileocolic means ileum entering the colon, right? This is the simple one. This is the most common one. Okay, this is the most common one. Which is most common? Come on, say. Ileocolic. Ileocolic is most common. Yeah. So otherwise you can have ileal, colocolic. That means ileal they fight amongst themselves and colocolic fight amongst themselves. That is different. But here small intestine entering large intestine. This is most common. Okay. Obviously it makes sense. Large is large. Small is small. Small will enter the large. Okay. Compound ileocolic. Oh, now this became more complicated. These two people fought with each other, became ileo. Then both of them entered colic also. No, ileocolic, that is compound. Retrograde jejunal-gastric intussusception, a complication of gastrojejunectomy, GJ, is rare but an interesting type of susception. Maybe we should look at a photo of this, then only we will understand. GJ we know. The stomach, they will connect to the jejunum. If you remember in stomach carcinoma video, you have already looked at this GJ, right? GJ. See this one, this is GG. Palliative surgery they will do for stomach cancer. They can see the carcinoma is here in the pyloric antrum, that side. So what they are doing here, they are connecting the stomach directly to the jejunum. Jejunum. So gastrojejunectomy. Okay. What is after the stomach? That is duodenum. They are not connecting to duodenum. They are connecting the stomach to the jejunum. This is gastrojejunectomy because stomach is also called as gastro. So gastrojejunectomy. In this, what will happen? They are saying that there can be retrograde jejunal-gastric intussusception. Now this is something we have to understand. Ileum is going into the colon. So your jejunum is going into the stomach. That's what they're trying to say. Looks like. Let's say the jejunum is going into the stomach. Oh. So the jejunum is trying to enter the stomach. Jejunal-gastric intussusception. It's a complication of gastrojejunectomy. So basically, why are you calling grade retrograde? Because the distal is going into the proximal. That's why, right? Yeah. Okay, so we understood the types, guys. Now, amazing, you have understood the types. Now, let us go to the causes. Why does this happen? Idiopathic, nobody knows why it happens. Dietary factor. Dietary factor means what? Around the age of this month, weaning of breast milk will try to slowly stop giving breast milk. Okay, and they will start trying to give complementary feeding. Now, what will happen is weaning alters the bacterial flora, and it will cause the enlargement of the Peyer's patches. This is something to do with the intestine and the lymphatics there, etc. So these Peyer's patches will protrude into the terminal ileum and may produce intussusception. So it's all about the Peyer's patches have to be blamed. They protrude into the terminal ileum. So basically, weaning is the alteration of bacterial flora. Alteration of the bacterial flora is causing an enlargement. Enlargement is another word that's important here. Enlargement of what? Of the Peyer's patches. They protrude into the terminal ileum. So who is the person who's affected the most? The end part of your small intestine. So the ileum, and it will protrude. What did we say? Ileum is the word here, and it will precipitate intussusception. So this is your ileum. Can you see your Peyer's patches here? No? Look at the ileum. Can you see these circle things? These are only your Peyer's patch. See, Peyer's patch, germinal center with lymphocytes. These are the ones. So obviously it's lymphocytes. They want to cause a lot of problem with the bacteria. And these bacteria flora got manipulated because of stopping of the breast milk. So what will happen? These Peyer's patches are going to enlarge and they're going to protrude into the terminal ileum and they will produce intussusception. So if this is the ileum is entering what? It's entering the large intestine, which here we have shown with the appendix. Here the Peyer's patches are increasing and they're protruding into the terminal lumen, and they will, along with it, pull the small intestine into the large intestine. This is the etiopathogenesis. Infective factor. After an upper respiratory tract infection with a virus, that is the rota virus, don't forget rota virus, it'll produce inflammation of the Peyer's patch. Okay. Guys, one more thing you should understand, it is not just rota virus which produces the inflammation of the Peyer's patch and causes the intussusception. Even when you take rota vaccination, some rota vaccinations have caused death due to intussusception. That's why they stopped those variety of rota vaccination. Okay, so rota vaccination, rota virus, both of these can cause intussusception. What does rotavirus cause? It causes diarrhea, isn't it? Adult intussusception. Why in adults it can happen now? You understood in children it happens because of weaning and rota and etc. But in adults, can you and me get intussusception? There is always a cause for intussusception. That means it's not idiopathic. Let's look at why you and me as an adult can get intussusception. What do you think? Why can you get intussusception? So adult intussusception can happen because of Meckel's diverticulum, polyps, tumors, submucous lipoma, carcinoma of your colon. Now this got your serious. If I have intussusception, it can mean that it can be because of a polyp, a tumor, carcinoma. I'm not happy at all. What is the other thing? First thing that they said? Meckel's diverticulum. Lipoma. We don't like lipoma either, do we? So this is why there can be adult intussusception. So we have looked at the etiopathogenesis of intussusception. Look at this image here. There is some image here. Let's try to look at it. So they're showing here there's an intussusception because of polyp. So you can see here how the bowel is looking. It seems to be like this and like this. Intussusception due to polyp looks like. Okay, guys, in children, they have just given a few more causes. You know that it is because of infection and that. It can also because of Hinoch-Schönlein purpura, IgA vasculitis, that is cystic fibrosis, celiac disease, that is which damages the gut, and hemophilia. These can be the other predisposing factors in children, okay. But adult, they told you it could be tumor, polyp, and carcinoma, lipoma. Oh God, we don't like all of them at all. Now let's move on, people. We are looking at intussusception in this video. So next, Now let us look at the clinical features. It can be a firstborn male infant, usually around 9 months. We told you, right, when they start weaning or they start the complementary feed, they mean. Boys are affected more, okay. The child screams with abdominal pain. We don't like this, poor baby. And it's associated with facial pallor. Red currant jelly stools is the characteristic. Please remember this, red currant jelly stools. Here they are showing you red currant jelly stools. Why? Because of bleeding due to mucosal ulcer. That is why this baby has facial pallor also. Makes sense, isn't it, people, that this baby is losing blood, right? So pallor. And this is all because of mucosal ulcer, mucus secretion due to irritation. And this is followed by absolute constipation. Absolute. There's no way his baby is pooping anymore. Red currant jelly stools and then absolute constipation. This red currant jelly stools are not found in adult intussusception. Yay! But the thing with ours is that we can have carcinoma. That's not nice. They can have vomiting. We already saw vomiting. No, they have not mentioned. Okay, vomiting can be there due to pylorospasm. Because of the pylorus of your stomach spasm, this person can vomit. Later again, they can vomit due to obstruction. Okay. So vomiting has two causes. Initially pylorospasm and later obstruction. What are we looking at, people, today? Intussusception. Very good. Invagination of one segment of intestine into another. We are looking at what currently? Which slide? Clinical features. Very good. In between the spasms, child sleeps but gets up suddenly with pain. In between the spasm, the child sleeps, it gets up suddenly with pain. Imagine the mother, how she must be feeling. The child is sleeping, she's happy, but she knows that any moment the child will get up and start screaming with pain. Not at all nice, right? See here, it's not just the child has pain, it screams with abdominal pain. Okay? So did you get it? Now where shall we go? We'll go ahead. As a doctor, what will you do? The child has come with these clinical features. So symptoms over. Now clinical features. Let's look at the signs. You will ask the mother to make the baby sit and she will feed it. And when you, with your left hand, you will examine the baby's abdomen. Okay, and you will stand in front of the mother and you will examine. You will feel a contracting hard mass in and around the umbilical region. Please look at this image here. Sausage shaped mass you will feel around the umbilical region. Okay, resonant it is because it has air, it's mobile, it can move freely. So you will feel a contracting hard mass around the umbilical. This is sausage shaped it is. Very important to write this in the exam, right? Emptiness in the right iliac fossa, that is dance sign, sign E, D, D, dance, D, dance, sign E, D, dance. So basically there is a dance sign. Who's dancing, by the way? Who's dancing here? Emptiness in the right iliac fossa. So in the right iliac fossa, where is this right iliac fossa? So here there is emptiness. Why is there emptiness in the right iliac fossa? Why is it dancing? That they did not explain here. So here we are. The emptiness is because of the intussusception, this place may have got pulled. Okay, they may have, whatever is there supposed to be here may have got pulled. Okay, so that is why they are saying that there will be emptiness or there may be a retraction of the right iliac fossa. So they are calling it as the dance sign. Okay, now there can be visible step ladder peristalsis. So you can see visible peristalsis. Obviously, why? Because there's an obstruction. The body is trying to push, and it is step ladder peristalsis. It is kind of increasing in one direction kind of thing, right? And rarely intussusception can be seen outside the anus due to long mesentery. Oops, this just became so complicated. If it has gone all the way, it can come out of the anus due to long mesentery. So it has such a long mesentery that let us say this is the rectum and here's the anus and this this is your sigmoid colon, let's say. Okay, so the intestine which has got pulled in so much because it's such a long mesentery that you can see it out of the anus. Whoopsie, that's kind of interesting. What is this mesentery they are saying? Do you know what this mesentery is? Just go back here in this diagram. It was there. See here, they've shown here this yellow color thing which is getting pulled in. Can you see? The mesentery is getting pulled in. So if this is so long, it can allow this to go so much deep and come out of the anus, looks like. So where are we now? signs, yes. Now here, rectal examination reveals blood-stained mucus on the examining finger. Blood-stained mucus. When you do per rectal examination, you will see blood-stained mucus. Very good. Then this is when you put your, this is in palpation. Okay. So there can be peritonitis in people who have not been treated. This is more like a complication of the intussusception, right? So do you know the complications of intussusception? It can become intestinal obstruction, dehydration, lack of blood flow, perforation, peritonitis, sepsis, shock. Okay. So basically this is according to the textbook. The mesentery gets dragged into the intussusception, right? What will happen? The blood vessels will get obstructed and there will be mucosal ulcer and hemorrhage. So this is why there is red currant jelly. There can be lymphadenopathy. Obviously that is why the Peyer's patches are hypertrophed, and that is actually the cause. I wouldn't say it's a complication. It's more like a cause of the intussusception. If the neck is too tight, gangrene will happen. This can be a complication, yes. And all the other features, strangulation, dehydration, distension, septicemic shock can develop later. Okay. So yeah, here we have put it as complication only. So now you have understood the complications of intussusception, and then now let us go to the investigations of Intussusception. That's quite a complicated spelling, isn't it? But they are saying it is intussusception. Oh, just an S. If I don't put an S, it's not wrong. Oh, it needs an S. Intussusception is correct English. Okay. Now let us look at the investigations you will do for these people. You can do barium, enema, claw, pincer ending. Yeah. Claw, pincer ending. So let us show you the photo for this. In the investigations, when you do barium enema, it will look like this. Look at this, how it is, the claw ending, because the next part of the intestine is inside this, right? So you can understand. So a claw pincer ending, it is the diagnostic feature of intussusception. It is also called as meniscus sign. Claw pincer ending, meniscus sign. All this is the same thing. Where will you see intussusception? What is intussusception? Imagination of one segment of the intestine into the other. If there is any suspicion of gangrene, this test should not be done. So barium enema you should not do. You should not do. Then write it here. Here only. Don't do in gangrene. Okay, if gangrene you're suspecting, you should not do. Okay. In many cases, the diagnosis is established on clinical grounds. So try to establish the diagnosis in clinical grounds. Then we'll write it here. We already told you the clinical symptoms, signs, go by that. Then barium enema if you want. If you suspect gangrene, don't do. Then always go for ultrasound. It's so much easier. It's the investigation of choice nowadays. It can detect target sign and detects the Doughnut sign with Doppler. Okay. It can be used to assess vascularity of the bowel, assess vascularity of the bowel. Thus, barium enema has become obsolete. Yes, barium enema has become obsolete. When you have ultrasound, we'll put it on top. Why don't they put a useful thing on top? Now, ultrasound basically can show you that Doughnut sign, target sign, all that, right? Like this. One inside the other. Doughnut sign, target sign. With the Doppler, you can even find out the vascularity, how the blood vessel, how the blood supply is, right? So if you can know it is going for gangrene. So barium enema has become obsolete. We love that because we don't want to have some enema in us. Do you? No. Any patient would prefer an ultrasound, isn't it? Yes. Now let's go forward. CT scan. That's the most sensitive imaging modality in the diagnosis. Which is most sensitive? Most sensitive is CT scan. Sausage-shaped mass with blood vessels within the bowel lumen are typical findings. So this is a, is this a CT? Yeah, it is a CT. You can see an intussusception. You can see the target. I mean, that kind of a round inside round we can see, but this is the intussusception due to polyp they are seeing. And here, let's look at this image. What is this image? It's a CT. So they're showing you an intussusception. Okay. And this one. Ultrasound, pseudo kidney sign, target sign, duplex, assess vascularity also. So yes, we can see they have assessed vascularity. You can see the red and blue dots. But okay, so just tell in the exam you have to write this. You will do ultrasound, which we have not put an image actually. Ultrasound, Doughnut, target, Doughnut, then barium, enema, claw, pincer, meniscus, CT scan, sausage shape mass. Okay. Yay, people, investigations over. What will you do next? Treatment. Very good. How will you treat this baby now? Hydrostatic reduction. Water static reduction. Put water and try to reduce it, is it? A lubricated catheter is introduced into the rectum. They will put saline. Okay, they will put a catheter, then they will put saline, 2 liters of saline, and they will allow it to run, and then the catheter is removed and the buttocks are pressed together, and in most of the cases, it will become proper. Barium sulfate in warm is it? Isotonic solution can be used. Some things have got cut here, isn't it? Air contrast enema will not reduce gangrenous bowel. So if there is gangrenous bowel, it will not reduce, obviously. Air contrast can cause more problem if it is gangrenous. Obviously, it can, I feel like it can rupture, perforate. Okay, they are happy with the saline and the barium sulfate in warm isotonic saline. Okay, we'll go with saline everywhere. They're saying saline, so we'll go with saline. Okay, next, when you should not do this peritonitis with shock, total intestinal obstruction. Okay, so better not introduce anything new there. That's what they're trying to say. Okay, when will this hydrostatic reduction be successful? When flatus and fecus are passed with barium. So with the barium, everything comes out. Child is symptom free, child is comfortable. Small bowel loops are filled with contrast. That means from the large intestine, it went into the small intestine. So these think that yes, it is successful. Are you understanding, people? What are we looking at? We are looking at the, when do you think this hydrostatic thing will become successful? Okay, when it passes everything, or the child is fine, or the small intestine you can see. Right, with the contrast. What is the advantages of hydrostatic reduction? It is easy, non-operative, and complication is that it can lead to colonic perforation rarely. Okay, so conservative treatment, hydrostatic reduction over. Now we will go to the next thing. What do you think is the next thing? Obviously, this is a surgery topic, isn't it? So what will you hear next? Surgical management of intussusception. What you'll do, you'll go and pull both of them out together. Our idea is, as surgery, you have to go and make this proper, right? So how will you do? They're saying you do go laparoscopically and reduce this, right? So you will milk it, kind of thing. You'll milk it and make it come out. You'll ask the adhesions and all, you'll remove with your little finger, with the little finger, raise your little finger, look at it. And with that, you remove all these adhesions at the neck, okay? And then, you can, if it is gangrenous, you'll have to resect it, okay? So this is the treatment. So they are saying if you want, you can do appendectomy, but I disagree with that. Whatever is the problem, we'll fix it now. Milk it, break the adhesions, gangrenous means resect. Then recurrent intussusception is rare if it occurs. If it occurs in this guy again and again, hold this terminal ileum, this is the terminal ileum, make it proper, hold it and tell it, I'm tying you to this ascending colon, no more entering the large intestine. Okay, so you tie it. Only if it is recurrent, okay, only if it is recurrent, and then you suture, ileum is sutured, okay, to the side of the ascending colon. That's it. So this is the treatment of intussusception. They said that in surgery, when you're doing, you can see marked lymphadenopathy and hypertrophy of the Peyer patch, right? You can see that in the operation, because obviously that was the cause of all this intussusception. So in this video, you have looked at a lot of stuff about intussusception, how the proximal part goes into the distal part, usually the ileum into the colon, the definition. You looked at in 1-year-old child, it will happen, it will cause intestinal obstruction, the parts of the intussusception, that is intussuscipiens, intussusceptum, apex, neck, etc. And then you saw what happens, the mesentery will get dragged in, the blood vessels will get obstructed, there will be mucosal ulcers and hemorrhages. This will lead to bleeding, right? Red currant, jelly stools. Anyways, the types of intussusception, ileocolic is the most common. Then you have ileoileal followed by colocolic. Then you have compound ileocolic, and then you have retrograde, like you have the in the gastrojejunostomy, you can have jejunogastric intussusception. The pathogenesis, you saw what happens, it's idiopathic, or in the weaning, the bacterial flora gets altered and there's enlargement of the Peyer's patch, they will protrude into the ileum and cause intussusception. Then if it is rotavirus, it can lead to this. And adult intussusception is usually because of Meckel's diverticulum, polyp tumor, submucosal lipoma, carcinoma, etc. In children, you can also see it because of Hinoch-Schoenlein purpura, that is IgA vasculitis, cystic fibrosis, celiac disease, hemophilia, etc. Now coming to the clinical features, you saw it will be 1-year-old, usually male. Child screams with abdominal pain. It will be sleeping, but it will suddenly get up and scream with pain. It can also have red currant jelly stools because of mucosal ulcer, bleeding. And then there can be constipation after this incident of red currant jelly stools. And in adults, you don't have red currant jelly stools, okay? These children can also vomit due to pylorospasm, and then they can vomit due to obstruction. The clinical feature signs are that you will feel a hard mass contracting around the umbilicus. This is a sausage-shaped mass. You can, in the right iliac fossa, you will see that there's emptiness because of the pulled parts of the right iliac fossa. You can see that's called as dance sign. Then visible step-ladder peristalsis. Sometimes if it is so much, the mesentery is so long, this part of intestine can actually be seen outside of the anus. Whenever you do rectal examination in a child, you can see blood-stained mucus, right? Yes, they didn't say child, anybody. You will see blood-stained mucus, and peritonitis can occur in untreated case. That's a complication. So the complications we have shown you, the blood vessels can get obstructed, there can be mucosal ulcer, hemorrhage, gangrene, there can be strangulation, dehydration, distension, septicemia, etc. There can be shock, peritonitis, etc., dehydration, etc. What investigations you will do? Ultrasound is the best. Then clinical grounds itself, you can try to establish the diagnosis. In ultrasound, you will see target sign, Doughnut sign. In barium enema, which is not done, you can see claw, pincer ending, meniscus sign. In CT scan, you can see sausage-shaped mass. CT scan is most sensitive. Then treatment, you can do hydrostatic reduction with saline, putting a catheter. Or if air contrast also you can do. In gangrenous, you should not do air contrast. Remember, if there is peritonitis or total intestinal obstruction, if there is peritonitis with shock or total intestinal obstruction, you should not do this kind of reduction, right? What are they saying? Yeah, they should not do. And how is this going to be successful? When do you know it is successful? If flatus and feces are passed with the barium, if the child is fine, if the small bowel loops are filled with contrast, that means it went all the way into the small intestine, then everything is fine. That's what you can understand. It is easy normally operative method, but the thing is it can rarely lead to the colonic perforation itself. That is why if the person has total intestinal obstruction, you should not do. And then intussusception surgical management, how you'll do, go with the laparoscope, laparotomy you do, and then you milk and squeeze in opposite direction. You break the adhesions of using the little finger and you remove this. This is the intussusception operation. If it is gangrenous, you just resect it and you do some ileocolic anastomosis. Recurrent intussusception, if it is happening, then you are going to suture this terminal ileum to the ascending colon. Okay. That's it, guys. In this video, you have looked at intussusception. Bye-bye.